I'll be talking about vernal keratoconjunctivitis. It is basically a chronic bilateral seasonal allergic inflammatory disease of eye involving the tarsal and bulbar conjunctiva, and mostly it is seen in children.
Rajesh, you can skip because I've finished vernal conjunctivitis. Just come to the management straight.
Okay. So mostly it is seen in children, and it improves at the time of puberty. As far as etiopathogenesis is concerned, mostly it is related to, it's an immunological reaction basically, and more often it is seasonal with itching and photophobia, but sometimes seasonal can get converted into a perennial one. And there are various ways of grading it. There's no need to investigate as far as immunological test is concerned, and there are certain complications that can be seen, and that is limbal stem cell deficiency. You can have keratoconus, corneal scarring, etc. So coming to the management part, the first and foremost thing is that you have a child with vernal keratoconjunctivitis, and it is such a recurrent thing and such a chronic thing that many times the parents, who are the main, main people behind the effective management, they need a proper counseling. Even the children need a proper counseling. That's very essential, and you don't have to keep rubbing the eyes. If there's any rubbing of eye, and chronic rubbing of eye can lead to formation of occurrence of keratoconus. So a good counseling is very important. As far as therapy is concerned, you have to give it, so pharmacologic therapy, and sometimes surgical therapy is needed in some scenarios. Now, as far as the anti-allergic drugs is concerned, we all know we have been using it. Initially, we used to give chromoglycate and antihistaminics. Now we have these dual-acting agents, so we have these dual-acting agents like olopatadine, bepotastin, etc. And these agents have to be used judiciously and regularly in combination with other drugs, like you can use cyclosporine and tacrolimus. Now, since these children, along with these, you have to give topical steroids. So you initially, when a child comes to you with vernal keratoconjunctivitis, then you have to give a cocktail kind of a therapy with a dual-acting agent, with a topical steroid, as well as, sometimes you do require, if you feel that this child requires a long-term therapy, you may start cyclosporine and tacrolimus, or either of these. And then gradually you have to assess how the patient is behaving. If there is a good response, in that case you can gradually taper off the topical steroid, and then you can continue the child on the patient on topical cyclosporine, topical lubricants. Lubricants are also very important because they wash off the allergens, they give relief as well. Sometimes they have giant papillae, so in that case you need some relief. So lubricant, and then you reduce these steroids, you continue on these dual-acting agents and lubricants, and at times cyclosporine or tacrolimus, either of these. And then gradually, as there is more and more response, you keep removing the drugs. But if the response is not very good, then in that case you have to do more. And in doing more, you have many times with this giant cobblestoning, giant papillae, you would like to give a supratarsal injection of steroid. These are mostly given in conditions wherein you don't have a proper response from the topical therapy. And this is mostly given, this is a supratarsal injection, so it is above the tarsus. You invert it and inject. I'll just show you the small video. You inject 0.5 ml of, Tricot, which has 40 milligram per ml, so you give 0.5 ml of that supratarsally. So this is how you inject supratarsal steroid, and this, you have to be careful in these cases. You have to monitor the intraocular pressure post-operatively very carefully, because if the patient is a steroid responder, then there's a risk of very high intraocular pressure. And there are conditions wherein people have reported of scraping of the steroid that was actually deposited there. So you have to be careful, but yes, if the child is not at all responding to the topical therapy, in that case you may have to use these alternative methods. Then people have also excised the papillae and covered the bare area with amniotic membrane. There is one group in Singapore which does it, and I had reviewed one article of one of those groups also. So they are very fond of removing those tarsals. I don't know any of us whether we do it, or I personally don't do excision of these giant papillae. And I prefer giving supratarsal steroid in non-responding ones. If you are giving a supratarsal steroid, I have a reasonable experience of supratarsal steroid in all these cases. So a single injection is not going to help. You have to give 3 to 4 injections, otherwise it will not respond. So you give one injection, wait for 3 to 4 weeks time, see how it is responding, keep monitoring intraocular pressure, and then you have to repeat it. So then if you have a shield ulcer, which can happen because of the rubbing of the giant papillae, then in that case you give a medical therapy. If there's a plaque, you have to debride that and put an amniotic membrane. And then of course for other complications, like if you have a corneal opacity, then anterior lamellar graft sometimes you have to do, and limbal stem cell deficiency has to be managed accordingly. So this is a shield ulcer wherein this plaque needs to be debrided, otherwise it will not heal. So you have to debride this plaque, and once you do it, you put amniotic membrane over it. Now, whenever you get these shield ulcers, you have to give all the medications. You have to evert the lid and see the giant papillae, which is present there in all the cases. And then you have to treat it just like any other allergic conjunctivitis. And if there's a plaque like this, you have to debride it and put an amniotic membrane. Sometimes while debriding, you get a deep gutter. In that case, you can do a multi-layered amniotic membrane in that gutter and put an amniotic membrane overlay over it, and that helps. And amniotic membrane can be kept in place with the help of fibrin glue. You can put additionally, in children, it is always better to put additional anchoring sutures so that it stays there. So this is the whole list of management algorithm that if the patient responds, you have to do this, all I have discussed. So in summary, in cases of vernal keratoconjunctivitis, it is always a combination therapy that helps. It's just, there's no single drug that is going to help. And nobody can say that this drug is better than that, but the dramatic response or the significant response is seen with steroid only. So you have to give steroid, taking care that you don't cause any complication related to it. And the therapy has to be long-term, and that's why my first point in management was a good patient as well as parent counseling. And you have to taper it. You have to taper the steroid. So that is why I would advise that you should not give a steroid antibiotic combination if you have, if at all you are giving some antibiotic, suspecting something or whatever. I mean, just by chance, if you have given an antibiotic steroid combination, you should not do it, because tapering of antibiotic is not advisable. So, but in cases of allergic or VKCs, you have to taper steroid. A regular follow-up with a monitor, with regular monitoring of intraocular pressure is very important, and you have to see to it that you prevent complications, see to it that the child doesn't rub the eyes, ask the parent that whether the child rubs his eyes frequently or not, because with that, there are risks of complications like keratoconus. Thank you very much for your patient listening.
Sir, I feel there is no question from vernal conjunctivitis, but I have met you in the podium, so I want to ask another question, not irrelevant to this. So, one patient, 25-year-old female patient, came to me with congestion both eyes.
If it is not related to vernal, we'll take
Conjunctivitis related.
We'll take it after he's making
okay.
a presentation. Any questions related to vernal conjunctivitis?
How long can we continue continuously these antihistamines in a patient who is responding to these antihistamines like olopatadine, etc.?
You have to judge the response, because you cannot give it for indefinite period, because olopatadine also causes surface dryness. So you have to judge. If the response is good, you have to keep, like, first you have to taper the steroid. Then if you are giving along with that anything like tacrolimus or cyclosporine, you have to stop that. Then this dual acting agent and lubricants are going on. Then if the patient is not symptomatic at all, then you may stop that, but continue the child on lubricant. See whether the patient is having recurrence of symptoms or not. And then if there is no recurrence of symptoms, just continue with lubricant. So this is how you have to judge with the response of the patient.
Dr. Sinha, which antihistaminic or mast cell stabilizer is your choice? Like we have
Mostly I
many
give
now.
olopatadine.
Yeah, we have a newer
Yeah,
antihistaminics
yeah,
also,
yeah,
so
yeah.
like Buponast. So do you have any experience with that, or how?
I do have an experience with that. The only thing is that, one or two studies are there which states that bupropion has an edge or advantage, but I didn't feel the difference actually. So I guess it's an old habit of continuing with olopatadine.
Dr. Maskati, I feel that we don't have a very good mast cell stabilizer at the moment. So whatever, they are all are equal and they are still suboptimal. What we actually want. What is your take on that?
I used to use only the olopatadine till the bupropion and the L-caftidine came along. And I have more or less now switched to the newer ones, but I tend to use them for 1 year to 2 years continuously without a break. With the olopatadine, as Rajesh correctly said, it's been reported that some amount of dryness is there. Now, whether it is due to the olopatadine or the disease process itself, in a vernal conjunctivitis, you tend to get dryness, perhaps because of all the preservatives, perhaps because of the disease process, and we generally continue with lubricants, so it's not such a big concern. But my take is that I treat them a little differently. I use steroids not more than pulse doses in a month, not more than 5 to 6 days of steroids maximum. But every patient is on either bupropion or L-caftidine continuously for a year or 2 years. And as you heard from my previous, I use a lot of tacrolimus and cyclosporine in these, so I reduce my steroid. I'm a great fan of SupraTarsal, and I do use conjunctival autograft rather than amniotic membrane. There is a small subset of your vernal conjunctivitis. For some peculiar reason, there is only palpable thing. The bulbar conjunctiva is quite quiet. So I postulate that the bulbar conjunctiva has got some agent which is preventing the papillae from occurring on the bulbar, which is not so in the palpable. So when I transplant from the bulbar, where there is no papillae, and scrape off all the papillae from the palpable, I tend to get better results than use of amniotic membrane. I've done about 25 cases of transferring from the bulbar to the palpable, like in a pterygium thing, leaving the limbus, sparing the limbus.
As you said, I have a lot of bias towards cyclosporine in these cases, because I completely agree that these patients per se, because of the disease process, they develop a poor ocular surface. So cyclosporine not only suppresses little bit of inflammation, it also helps in improving, because of that reason also it improves the ocular surface. So both ways it acts as an anti-allergic as well as improving the ocular surface. So
another newer drug which I've been using frequently is Rebamipide. Now, Rebamipide has to be put 4 times a day. You can't reduce it to 3 times, 2 times. It works only at 4 times. In about 15-20%, they get a very bad taste in the mouth, so you have to stop this. But the advantage of Rebamipide, especially if a patient complains of not only itching, but if there is some burning sensation, that means you know that there is dryness. Rebamipide is a very weak anti-inflammatory agent, so it suppresses the papillae also. But at the same time, it is the anti-dryness agent, like it improves the lubrication. So Rebamipide 4 times a day for about a month, 2 months, sometimes 3 months, I do tend to use.
So what I have noted with Rebamipide is that after 2 hours, the patient again requires 1 drop. I mean, that's what some of the patients have told, that it gives immediate relief, but then in 2 hours time again they start feeling...
That time you ask them to add lubricant.
Yeah,
The
yeah.
rebamipide should be strictly
Yeah.
4 times a day.
Yeah.
Because otherwise they get a lot of this.
A lot of the
dysgeusia.
two problems that they have reported, that some complain of some tightness of lid and the bad taste. Two things that people have reported with.
We have a question.
My question to Dr. Rajesh Sinha, sir.
Sir.
Nowadays, there are combination of ketorolac plus olopatadine. Do they have synergistic action? It's better than single medicine, olopatadine?
They do have synergistic action. I mean, the studies have proven, and it does work. Like a combination of ketorolac with olopatadine is available, which I also personally use many times. But not before using that, you have to see whether the ocular surface is okay or not. If it's a long-term, VKC or AKC or ocular surface problem, in that case, combining NSAID may be a little, detrimental. So these things you have to judge depending about the patient.
What about mast cell stabilizer?
Yeah, olopatadine is both mast cell stabilizer as well
And
as
antihistaminic
antihistaminic.
as well.
So it's a dual acting drug. So.
Right, thank you.
We've stopped the use of pure mast cell stabilizers. We used to use cromolyn sodium. We've stopped using that now once the dual action drugs came in.
It's not used nowadays.
Yes, that's what I said. We have stopped using it once the dual action drugs came in.
So, sir, one last question to you, because you use a lot of tacrolimus. Are you facing some amount of compliance issues with patients because of the complaint of pain and stinging, and how do you deal with it?
Almost 15% of the patients will complain. So when I prescribe them, I tell them straight away that you will get this. Try and overcome this by using lubricants 5 minutes after. If they cannot tolerate, we'll have to stop it.
For this, we have been using tacrolimus for more than 10 years. Initially, there was skin ointment that we used to tell them to rub on the lid margins. So these tacrolimus, what we have now is generally the patient, they get compliant after some time. It's just that the initial phase they have to overcome. If you just counsel them and tell them that it's okay, it will be all right. As Dr. Maskari said, you tell them straight away that it's going to burn. And if it's burn, it's good. It's good for you.
Yeah,
So, then they carry on. After 2-3 weeks, it becomes all right.
I think, sir, the first 4 days is really bad.
Yes.
I've tried using it in my eyes for a few days, and it's quite painful, but usually by the 5th day, if you really have allergy, it will start helping your eye and you'll not feel the pain.
True.
And patients who are more acute in presentation, they tend to comply much better, because I think they already have a lot of symptoms and they don't feel the burning as much. So, yeah.
Before we go to the last presentation regarding cyclosporine, sometimes these vacancy is really severe, and what we see here as compared to the West, we see quite severe patients, and they tend to have stem cell deficiency also. So sometimes you need systemic things also. Sometimes you need a small course of systemic steroids. And what I found is systemic cyclosporine also works beautifully well. That's a very small subset of patient, but that has when it's not responding to anything that.
Systemic anti-allergics, I have been using it, but I have not used systemic cyclosporine in cases of VKC.
I've
But
been using systemic steroids for very young children, 5-6-year-olds, at very low doses.
Systemic montelukast and fexofenadine combination is a good one
Yeah, I
for
agree, I
initial
agree.
response.
Yeah, but I've been using omnacortil and Visalone for very low doses, but for an extended period of time, maybe 3 to 4 months, for very bad cases of 4-5-year-old kids. And they seem to respond very well. All their atopy as well, other things also.
Actually, this vicious cycle has to be broken, and then that can be done with steroid. I
A
think
small
we should-
segment of patients who got allergic, atopic dermatitis, asthma, so when there is more than 2 of areas of allergy, I do a desensitization for them with an allergy specialist. And I've got about 6 or 7 such patients who've done well, but it takes a long time, 6 months and more.
It's amazing, sir, that many of these patients, even on long-term steroids, who have these syndromic features of allergy all around, they don't tend to get Cushingoid features even after 3 or 4 months, which is very odd, because we don't see that in adults or in any other kind of patients. I think that their inherent steroid level, corticosteroid level in their blood is low, and by giving that, we're just making them feel healthier and better. And yeah.
So we have good cases coming up from my end.